Hello and welcome to Health Professional Radio. I'm your host, Neil Howard. Thank you for joining us for another segment. We're going to be speaking with Dr. Timothy Pawlik and Dr. Samilia Obeng-Gyasi in this segment. Both of them are surgical oncologists from the Ohio State University Comprehensive Cancer Center. They're joining us to discuss some new studies that were published in Psyco-oncology, a study that finds the risk for poor cancer outcomes in patients with overlapping inequities is higher than historically marginalized groups. Welcome to Health Professional Radio, both Dr. Pawlik and Dr. Obeng-Gyasi. Thank you for joining us.
Thank you.
Thank you for having me.
Well, Dr. Pawlik, a brief look into your professional background, if you would, and then Dr. Obeng-Gyasi, if you would tell us a little bit about yourself as well.
Yeah, sure. So my name is Tim Pawlik. I'm a surgical oncologist is my clinical background. I largely treat patients with liver and pancreas cancer. And then I'm also the chair of the Department of Surgery here at the Ohio State Wexner Medical Center and the James Comprehensive Cancer Center.
And my name is Samilia Obeng-Gyasi, and I'm a breast surgical oncologist here at the Ohio State. I'm also a health services researcher with a focus in health equity.
Well, first of all, what were some of the major findings from this study?
So we know that there are a number of disparities with regards to access to care and outcomes to care relative to a number of different factors, social factors, including race, ethnicity, socioeconomic status, and even where people live. One concept that has garnered increased interest has been this notion of intersectionality. And that is this concept of how, maybe multiple historical and social factors and identities that patients may have, the interplay amongst these things that may further impact a patient or individual's ability to access care and also impact the outcomes of their care, post-treatment.
So how did you conduct the analysis?
So this was a systematic review of the literature where we looked at studies among cancer patients. Specifically, we were interested in understanding how they conceptualize this idea of intersectionality. As Dr. Pawlik mentioned, it's actually a qualitative analytical framework developed by Professor Crenshaw. And it's the idea that individual social identities, this includes race, class, sexual orientation, and also gender, can act synergistically to affect how they experience discrimination and also how they experience disadvantage. So we wanted to see that among individuals who have cancer, how has this concept really been used in the literature, and what are the implications for these patients in terms of their oncologic outcomes?
Is it that historically marginalized groups are going to be even more marginalized if they have these overlapping identities?
So essentially, that's what we found. So we found that individuals who have multiple social identities that have been historically and intentionally excluded tended to have limited access to care. They had less than ideal patient-physician relationships, so higher levels of mistrust. And also overall, this led to poor oncologic outcomes, such as higher mortality or death from their cancer.
And just to follow up on what Dr. Obeng-Gyasi has said, what was interesting is that these disparities existed across the entire continuum of care. So screening, diagnosis, treatment, as well as survivorship, which is important to note that this isn't isolated to just access to surgery or specific elements of care, but really was something that impacted patients across the entire continuum of cancer care.
The pandemic really shined a glaring light on many of these inequities, but were the results of this study shocking to either of you?
No, it was not. So, we've always known that individuals from historically and intentionally excluded backgrounds have had poor outcomes, whether it be in oncology or within chronic illnesses such as diabetes or hypertension. So the results were unsurprising.
Unfortunately, they weren't surprising to me either. Mm-hmm. I think one of the novel things about our study is that we know that there are disparities related to race, ethnicity, socioeconomic status. What this study specifically highlighted also, though, is that the intersection of many of these things, if you're Black and poor and lesbian, those combinations of your identity can even put you at greater risk of disparities with regards to cancer care, screening, and outcomes. So I think one of the important points of the study is this whole notion of an intersectional lens, and to understand that, all of us as people are nuanced and complex and, identify in multiple different ways. We're not just one thing, we're many things. And how can we, as providers, really meet people where they're at and appreciate their full lived experience to make sure that we can fully engage them and provide them the care that they need.
Was there a huge gap between deliberate and intentional bias causing inequities, or simply not understanding different cultures, lifestyles, and identities on the part of healthcare providers and the system that surrounds them?
So the study was not that granular in terms of looking at the underlying causes of these disparities or inequities. It was more of a descriptive study looking at existing studies and trying to sort of understand how the intersection of multiple identities affect, access to care and also quality of care and outcomes from care. But I think, future studies, possibly qualitative studies, looking at talking to both providers and patients might provide some better insight into some of the factors that might be contributing to these inequities based on multiple social identities.
So do you think that an understanding of this intersectionality is going to be readily accepted in the medical community to ensure better outcomes for these patients?
So one of the good things about the COVID pandemic is that I think for all of us in the healthcare field, we now have significant evidence that individuals who face adverse social determinants of health, and adverse social determinants of health include, poverty, include limited access to resources, have poor outcomes. Individuals who live in neighborhoods that have a low socioeconomic status or who are individually of low socioeconomic status have the highest incidence and mortality from COVID. So I think over the past sort of 2.5 years, we've had a bit of a reckoning in our community that it's really important for us to understand our patients in terms of their living conditions, their working conditions, how they view themselves and how the world views them, as this has significant implications for their access to care, and also more importantly, how we deliver care to them and how they receive the care that we deliver.
Was there a lot of analysis into the medical community or the patient community in this study, or was it an equal combination of both?
So we looked at studies that have examined the patient-physician relationship to better understand how individuals who are from historically marginalized and minoritized groups, how they perceive those relationships, and also how clinicians perceive them. But this is a review of other studies that have been done. It wasn't a study where we did the analysis ourselves. But I do think that future studies will head in that direction because it will provide us with more granular information about both the physician and the patient perspective about the doctor-patient relationship.
The other thing that was interesting about this study is, as Dr. Obeng-Gyasi notes, we kind of summarized the existing literature and research on this topic. And one point to highlight is that there's not enough research and literature on the topic. So while we did highlight previous findings, one important takeaway from our paper also is the need to have additional research on intersectionality in oncology. And part of the paper indeed highlights kind of a multiphasic model for intersectionality research in oncology that we're hoping will be recognized and embraced by the cancer community. So more important work can be done on this topic.
Give us a website or some resources where our listeners can learn more.
And so the first step probably is to read our paper, because that paper actually provides the overview that Dr. Pawlik just discussed. And also the framework that's been developed, I think, is going to be very useful, not just for oncologists, but might even be able to be extrapolated to other chronic illnesses, as I've mentioned before, like diabetes or hypertension. So that's sort of the first place that I would start. And then there's a lot of research right now on intersectionality, not just in oncology, but also in other aspects of healthcare. And so accessing that kind of literature should be very easy by essentially just going to Google and looking it up.
Well, Dr. Pawlik and Dr. Obeng-Gyasi, thank you both for joining us here on Health Professional Radio this morning.
Thank you.
Thank you for having us.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Timothy Pawlik and Dr. Samilia Obeng-Gyasi. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download at SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com/Health Professional Radio.